Welcome back to season 4 of
A Couple of Multiples.
The Reality of Dissociative Identity Disorder. Did you know that according to a recent Harvard study, 93% of people living with DID are initially misdiagnosed by mental health professionals? That's a staggering statistic, and it's exactly why we're here.
This season, we're diving deep into clinical interventions. What actually helps when it comes to recognizing and treating dissociative disorders? Whether you're a mental health provider, a supporter, or someone navigating life with multiplicity, this season is for you.
Thank you for being here. Please share this episode with a friend, your therapist, psychiatrist, or colleague. Together, we can help improve access to accurate diagnoses and effective, compassionate care.
And most importantly, remember that every system is different. What works for one may not work for another, and that's okay. Your journey is valid, your healing is real, and we're so glad you're hanging out with
A Couple of Multiples. This episode is brought to you by Donna Earle, a licensed professional counselor and certified clinical trauma professional.
She's the founder of To Life Counseling in Southlake, Texas, where she helps individuals ages 17 and up heal trauma, navigate identity, and reclaim inner peace. Her trauma-informed approach includes EMDR, parts work, strengths-based therapy, TBRI, and CBT.
She's passionate about honoring the resilience of the human spirit, one story at a time. Today's episode is brought to you by
Healing Selves Therapeutics, PLLC, a mental health practice located in North Carolina, specializing in the treatment of dissociative disorders and trauma. Healing Selves is committed to serving the plural population through the utilization of EMDR, clinical hypnosis, expressive arts therapy, and other evidence-based practices.
Healing Selves was established in 2019 and currently serves North Carolina and Florida. We are committed to extending accessibility and currently accept most commercial insurances, Medicaid, and Medicare.
Welcome, dear friends, to another enlightening episode with Drew
and Garden System,
A Couple of Multiples.
The Reality of Dissociative Identity Disorder.
Today, we are going to talk all about inpatient hospitalization treatment plans for people living with a dissociative disorder. And we have Donna Earle, MA, LPC, CCTP, here with us to share her perspectives and insights to help clinicians, behavioral technicians, and hospital administration staff understand the unique needs patients with dissociation have while in crisis.
Donna Earle is a licensed professional counselor and certified clinical trauma professional with a master's degree in counseling psychology and a bachelor's in psychology from Texas Women's University. She is EMDR trained and has recently completed all requirements toward EMDRIA certification.
Donna brings nearly a decade of experience providing compassionate, trauma-informed clinical care. She is the founder of To Life Counseling, a private practice based in Southlake, Texas, where she specializes in working with individuals healing from complex trauma and dissociative disorders.
Her journey into trauma work began during graduate school, where she completed her first and second practicum placements on the trauma unit of one of the few inpatient facilities in the country at the time treating DID. Her very first client there had DID, a moment that profoundly shaped her clinical path. Donna trained at the facility for a full year, then returned after licensure to work on the trauma unit for another 2.5 years. The unit served clients with PTSD and comorbid diagnoses, including major depressive disorder, generalized anxiety disorder, borderline personality disorder, and dissociative identity disorder.
Donna continued her training at the Irving Family Advocacy Center, where she spent 6 years providing trauma-informed therapy to victims of crime, domestic violence survivors, and adult and child sexual assault victims, working closely alongside local law enforcement, victim services, forensic teams, and CPS.
Donna's therapeutic approach is integrated and deeply client centered. She draws from strength based therapy, trauma model therapy, cognitive behavioral therapy, CBT, dialectical behavior therapy, DBT, trauma based relational intervention, emotional freedom techniques, that's EFT or tapping, and eye movement desensitization and reprocessing, EMDR, to support healing.
Her passion lies in walking alongside survivors as they heal trauma wounds, reclaim their sense of identity, deepen self understanding, and discover inner peace. Donna's work empowers clients to embrace their journey, celebrate life, and step fully into the strength of who they are. She brings warmth, clinical expertise, and a deep respect for the resilience of the human spirit to her work and to today's conversation, to life.
Welcome, Donna. We are so happy to have you here today.
Thank you. I'm excited to be here. Thank you for inviting me onto your show.
Oh, you are welcome. All right, so we're ready to get started here. So, first question, would you please explain the differences between intensive outpatient IOP, partial hospitalization programs, the PHP, and inpatient residential programs?
Yeah, absolutely. I'd love to do that. That can be so overwhelming, and people often have questions because they're like, what are all these options and what do they mean? So, yeah, let me start with inpatient residential because there are two types of inpatient. Inpatient residential is 24/7 supervised care. You live there for a period of 30 to 90 days, sometimes longer. It's extended, intense care. Um, you also, when you're living there, you will have, of course, daily therapy, group therapy, recreation, medication management, and so forth. But it is really for individuals with severe mental health issues or addictions,
Mm-hmm.
those who need really structured, substance-free environment. Because, as you know, most people that are a lot of mental health conditions, there are a lot of comorbidities, and one of them happens to be addictions of some sort.
Right.
Absolutely.
Alcohol, sex, gambling, it could be anything, cutting. It could be a myriad of things. So they want to make sure they address all those issues. So it's also a step up program. That's how I refer to it. When other facilities haven't worked, when outpatient hasn't worked, when regular inpatient hasn't worked, and the client or the patient is not getting better, and they need more consistent, structured care. So that's the first one.
Mm-hmm.
And then I'm going to talk to you about inpatient, regular inpatient hospitalization. This is going to a specific psychiatric hospital. Some major hospitals will have an inpatient program as well, some county hospitals and such. This program is typically a minimum of 72-hour program up to 30 days. And you live on site. There's a series of group therapies. Some programs offer individual therapy where you get to meet once, twice, or 3 times a week with a therapist. However, what I'm hearing from my colleagues and from my clients who I've sent to hospitals, the therapy part is pretty much non-existent anymore. Everything is groups. So you're there, you live there, you stay there, they lock the doors, you're locked on a ward for safety and protection. You have medication management, you have a medical team that works with you. And they basically are meeting every morning, reviewing case reviews, They have a lot of difficulty trying to keep you in as long as you need to stay, because insurance, as we all know, that dirty word, is constantly trying to move the patients out. And a lot of their time is spent trying to validate and justify the reasons for you to stay.
Yeah.
So, but you do get good care there. So when you're inpatient in a psychiatric hospital, the reason or the primary focus is to stabilize the crisis. Clients and patients that go into these hospitals are in crisis mode, and they're not able to receive the care they need in therapy or in a community setting or in a partial hospitalization program. So that's the first thing, is to stabilize the crisis, very safety oriented, ensuring that you are in a safe environment. Detoxification, if you have a substance use disorder that's co-occurring, the first thing you receive is detoxification. So your treatment team in a psychiatric inpatient hospital will be the therapist running group therapy, a rec therapist, sometimes a dietitian. If it's a really good hospital, they're going to try to treat the whole body.
Right.
So they're
That's
going to try to
amazing.
make sure you're being nourished properly, hydrated. You'll get some good education there. And of course, nurse practitioners and sometimes psychiatric nurse practitioners or physician's assistants to help you. And social workers. Also, with the inpatient hospitalization program, they start working towards discharge to find longer term care if you need it, or step down care. So they do try to help bridge from one treatment to the other. So that's the two longer term facilities. Now we have some intermediate programs, and I'm sorry, I just want to look at my notes to make sure I don't miss anything.
Absolutely. Yep.
Okay, so we have partial hospitalization, which is typically a step down. Well, you have a choice. I have had patients go from inpatient to partial hospitalization or into the IOP program, which is a more intensive. Depending upon where you are in your journey, recovery journey, will determine where you go. Partial hospitalization, you typically go for about 5 to 8 weeks. It varies, and you're going every day for about 5 hours or so. Group therapy, again, a lot of education, just a lot of working with you and trying to help you stabilize and learn skills that you need to do, to learn what you need to do when you get out.
Yeah.
The other one is IOP, and IOP is a good program too. It's an intensive outpatient hospitalization program, and it's for patients that have mild or moderate mental health issues who need more support than they can get in outpatient, but they don't need the 24/7. So they're there 3 to 5 days a week for about 3 or 4 hours a day. They don't stay overnight. And again, it's all focused on group therapy, life skills, relapse prevention. And sometimes in a few, you can get medication management and support. And if you're really lucky, some family therapy, which is important, which is an issue in itself. The patients come into the hospital seeking care, needing stabilization, needing the skills they need. They need to do well at home, but then they're discharged and sent back into the very environments they came from that
And
may
that
be
can be
triggering.
problematic.
Yeah.
Definitely.
And so it's sort of like you're putting a Band-Aid on the problem, but not solving the whole problem.
Yeah.
So
Yeah.
family therapy is an important component as well.
Absolutely. Yes.
I do have some names of some facilities that are recommended for clients with DID. Would you like for me to share some of them?
Absolutely, because I
please.
know we are definitely in need of knowing where can people go.
Mm-hmm.
And that's a great question. We used to have options. At one
Hmm.
time, we had 3 or 4 options, and I think
Right.
now we're down to just maybe 3. Well, let's say we used to have 6 or 7 options, and I
Yeah.
think now we're down to 3.
Hmm.
So the ones that are well known is Sierra Tucson in Arizona. I have
Okay.
had clients that go there that have gone there for residential treatment, and
Hmm.
they found it very helpful.
Hmm.
Another one is the Sanctuary Centers in Santa Barbara. I
Hmm.
just learned of this one, so I don't know much about it, but
Okay.
it does offer long term integrative care for complex trauma and dissociation. So,
Okay.
Nice.
I
a
like that
little
they
bit,
say dissociation.
they do.
Hmm.
And they have residential and outpatient
Hmm.
options. So that's sanctuary centers.
Okay.
Sierra Tucson does offer, we talked about it, it's an integrated program. I
Hmm.
have had clients with DID and severe trauma go there, and they did very well.
Okay.
Nice.
But their information sheet didn't really talk much about that. So we might want
Okay.
to revisit. Another one that I've also sent clients to with great success is the Meadows in
Hmm.
Wickenburg, Arizona. And
Hmm.
there's also a Meadows right outside of Dallas that
Okay.
also can be a PHP. It's a
Hmm.
private trauma focused residential treatment center in Wickenburg. It
Hmm.
treats complex PTSD, DID,
Hmm.
and developmental trauma.
Oh,
They're really
Wow.
a
fantastic.
good program. They use they use neurofeedback,
Hmm.
EMDR,
Oh,
somatic
nice.
therapy, and group
Hmm.
work. So
Nice.
a lot of good work there. The one in Dallas, I believe, also does biofeedback, and
Oh, nice.
some of the facilities, and I'm not sure if it's this one, may have been one I heard in Colorado. They also do cryotherapy and all sorts of things.
Wow.
So
Okay.
the other one, River Oaks Hospital and Trauma Program in New Orleans, it includes internal communication training and stabilization work, and that's what they say.
So
So
cool.
those are a few.
Hmm.
There's a new one on the horizon that I heard about a couple
Okay.
of weeks ago at a
Hmm.
conference I attended. It's called Chiron Clinics, Khiron. It's
Hmm.
a global trauma recovery clinic.
Okay.
So it's in the United Kingdom,
Oh.
far away. They
Hmm.
pay for your airfare there,
Nice.
and it is a residential treatment center.
We do
So,
have a lot of listeners from the UK,
We
so
sure
this could be an
do.
option for
oh,
them.
wonderful,
Yeah.
great. Well, this clinic has the people that work there, the training is like groundbreaking. The
Wow.
people that they brought in to train everyone are phenomenal. They're the who's who of
Hmm.
trauma therapy. Dr. Bessel Vanderkolk,
Hmm.
Dr. Janina Fisher, and
Hmm.
Dr. Stephen Porges himself of
Hmm.
polyvagal theory. And let's see, what's her name? Dick Schwartz and Deb Dana are also
Hmm.
listed as the trainers.
Wow.
And so it looks like a fabulous facility.
Hmm.
I might have to go check it out.
I know. Sounds
So cool.
interesting.
Yeah,
So,
spend a week in the UK, see if I can
yeah,
get
arrange
some
that.
help.
Yeah.
So the only other thing I want to add before we go, move on to something else. When you're looking at a hospital,
Hmm.
really important, especially if you have DID, complex trauma,
Hmm.
trauma informed hospital.
Hmm.
And not just, they don't just say the words, there's some
Right.
meat in that. Okay.
Right. Anybody
Hmm.
can say I'm trauma informed, so you really need to do your homework.
Exactly. And,
Yes.
hopefully find one that has a trauma unit that is
Yes.
dedicated specifically to trauma.
Hmm.
You don't want a general psychiatric hospital.
Hmm.
Um, because those are best for short-term stabilizations, and the populations in there can be mixed. So with DID, any other complex traumas, you really need to make sure you're in a safe, secure environment that know how to treat and provide the care that you need.
Absolutely.
Yeah. So we can definitely put some links in the show notes to check out each of these places. And I think it's important that we kind of also note that we're not technically endorsing or recommending any of these places, but these are options that we have discovered for people to look into and check out for themselves.
They exist.
They exist, right? You know, and if anybody goes to these places, we would love the feedback.
Yeah.
To share with other people, because we know how hard it is to find a place to go.
Right. Right.
Yeah.
Right.
Well, thank you for that. That was very informative.
Oh, you're welcome.
Perfect. So when should a client with DID seek out inpatient hospitalization treatment?
Oh, I think that's a great question. And I would say people that have DID, complex trauma, the same triggers that result in inpatient hospitalization for everyone else apply. Number one, if they're in imminent danger of risk to themselves or someone else, at that point it's critical. Active suicide ideation or past suicide attempts, you have a plan, you have a means. Absolutely. If you have self-injury that you're losing control of and it's escalating, you need some help, please. I mean, that can be very deadly as well.
Right.
Even if you don't mean it to be, it can
That's
be.
right. Exactly. I mean, even if you don't mean it to be a little bit too deep, one direction or another. And of course, if you're having homicidal ideation or violent behavior, if you feel like you're out of control, your anger part is just has no way to, they need help.
Yeah.
That would be the first one. I think another criteria is if you are experiencing significant loss of time or dangerous dissociation. You're finding yourself in a different city. You don't know how you got there. We all know that there are variations and things that can happen. If your dissociative episodes are prolonged and too frequent and you can't seem to get yourself regulated, that would be another important thing.
Those are good things to consider.
Yeah, if you're wandering or you're blacking out or you're getting lost. I mean, we all know there's dangers in that. There's a danger to yourself of someone else hurting you. If you're engaging in high risk behaviors without awareness, man, we need to get, you need to get protected. If your alters or other selves, parts, I know everyone refers to them differently, are out of control or they're struggling, or you have one that's really depressed or, acting out, they need help. It's time to get in and get treatment. And again, wanting to find a facility that will treat all the selves, not just one.
Correct.
The physical body and the internal system as well.
Yeah, and that's really important too.
Yeah, that is.
And so kind of going to my next question, which is similar to one we just asked, like when should a therapist recommend that a client with DID be admitted to an inpatient program, and when should they involuntarily hospitalize someone? And I think this is important to really talk about, because I know some people kind of do involuntarily hospitalize people a little too soon, a little too quickly. And then I think sometimes, like really understanding, like when you involuntarily hospitalize someone, what that really does to the trust and therapeutic relationship, and so like really being careful when you do that involuntary hospitalization. Like if you could talk about that, I think that would be great.
Absolutely. I just want to add real quick go back for just a minute.
Yeah.
I forgot to mention something. Okay. If you're having your co-occurring disorders like major depressive disorder, psychosis, PTSD, You know, if you're having a psychotic break, which just is possible, then of course you want to seek treatment. Or if your
Right.
flashbacks or intrusive thoughts, intrusive memories are too much, that would be another one. So, and then to go to your question, yeah, I think that's a hard one, right?
Yeah.
When to involuntarily treat somebody.
Yeah.
I've never had to do it, thank goodness.
Oh,
I
thank
hope I
goodness.
never.
Yes.
I hope I never do. I believe in the philosophy that you talked about. The therapeutic alliance is so important, and trust is so important. If you're a therapist and you're seeing your client regularly, you know them, right? You know what's going on. So and I may get a lot of pushback from this, but I think part of my job as a therapist is to be in tune what's going on with my client and try to stay ahead of it, you know, to be preventative rather than getting to a point where the client or patient is, you know, really severe. So, how I handle it in my practice is we start having conversations. We have a very good safety plan that we work out, which we can talk about a bit later, which involves the other selves, getting
Yep.
everybody on board. But I'm very open and honest with my clients about what are the trigger points that activate step one, step two, and step three. And I also have them sign ROIs so I can reach out to the person that they want me to contact should their suicidal thoughts, passive suicidal ideation become more intense or has gone to another level and it's a point where we need to go to the hospital.
Right.
I just simply sit down and talk with them, and we talk about my primary job is your safety, to keep you alive,
Right.
keep you safe. And let's find a place together. Together, let's find some place that will work. And I pull out a list of places. I'm happy to make the phone calls for you. You know, you can listen or I can hand you the phone and what have you. And then who do we call to come and pick you up? I
Yeah.
don't want to traumatize them anymore.
Right.
So I'm not calling the police and having them taken away in handcuffs. And like I said, I've never had anybody involuntary, but I think I would handle it the same way. It would be a crisis therapy session that I would keep them there until together we could agree that this is in, and
Yeah.
also the other selves. I will probably be having conversations with the other selves and trying to get them to help me,
Yeah. The cooperation.
the
Yeah.
Right.
cooperation, and to understand. And sometimes part of that involves orienting the person to their body because maybe they're dissociated, maybe they're so depressed that you know, and so just the simple remember we're all sharing this body, and what
Yes.
happens to the body happens to us all.
To everyone. Yeah.
Right. Good reminder.
Yeah.
So
Not all the selves sometimes realize that. They don't realize that
right,
everybody will be gone. Yeah.
right. And you know, I have worked with some clients who I've had, you know, and just recently thought that, you know, this was my body, and I said, well, you share it, but let's look down at your body and tell me what you see. You know, this person, this self, was an African American male in a white female body. Hadn't really looked or noticed, didn't know. And it
Yeah.
was quite, I don't think I can use the words,
It's
but
disconcerting when you look at your hands and your body and you're like,
And they
this
don't feel
isn't
like
mine.
yours.
absolutely. And I validated that this must be really upsetting to you. What is
Yeah.
this like? You know? But again, re emphasizing so whatever you do to the body, you do to everyone. And whatever, you know, this other self does to the body is going to hurt you as well. And once they understand that, then they're on board, and now we can do something about it. I hope I answered your question.
I think it was well answered.
Yeah,
Yes. Yeah.
in a trust building sort of way, and not
Yeah.
taking
I think
it
this
away.
is really important that I would really like all mental health professionals to hear is like the importance of, doing this carefully and not just making the phone call and carting away, or doing it without trying to make a safety plan first.
And I'm fortunate enough that I have an office that is owned by a psychiatric nurse practitioner. So I have 2 psychiatric nurse practitioners there. And we often consult, I refer my clients, and so we know our clients. So I'm fortunate that in a situation, if I was really concerned, I have someone else I can bring in as an ally that they know. But that might be the only other thing is I would get a hold of an ally that loves them and that we have permission to speak to, that wants to see them live too.
Yeah.
Yeah.
It's beautiful.
All right. What are the benefits of seeking inpatient treatment for dissociative identity disorder?
That's a good question. It's kind of a tricky question now. As we mentioned earlier, we don't know of that many facilities, but if you can get into a good trauma-informed facility that is familiar with dissociative identity disorder, let's say you've never been to a therapist, right? Let's say you have dissociative identity disorder, but you don't really know you do. You're not sure, but you're having all these symptoms and you are in a facility, and this does happen, right? People get diagnosed. You may have been misdiagnosed 12, 15 times with other things, but you find a trauma-informed care with people who know, hopefully are educated and know about this, and they discover it. Wow, what is that going to do for you, right? Treatment planning, directing you to, a therapist that can help you, giving you the language that goes with what you're struggling with. There's a whole language associated with dissociative identity disorder.
Yeah.
And I think probably the biggest benefit, besides being able, the stability and crisis monitoring, all of those things, I didn't say right off the bat, it kind of goes unsaid in my mind, but once you're stable, your medication's regulated, you have multiple eyes looking at you, multiple sets of eyes, and they're together coming up with what's going on with you and a treatment plan and getting you some relief. The other thing is the group work. You're going into groups and you're able to sit and observe or participate. And I think you learn very quickly, I'm not alone.
Yeah.
There is somebody else that is struggling like me.
And normalizes the experience.
Yeah, DID can feel so lonely sometimes. So when you get around other people, you're like, really? Okay, I know what to do now. Like, you get there.
Or someone will say something that they experienced, a thought, a feeling, and they're like, oh my gosh, that happened to you? That happened to me. So there's a sense of community that can develop there. And for some people with mental illness, or many people, they feel isolated.
Yeah.
And that isolation is what creates deeper depression, right? We remove ourselves from everybody. And now maybe you begin to learn when it's safe. I think hospitals and inpatient facilities like that, you can learn boundaries, which is really important.
Oh, boundaries are so important. Yes. Ooh, and that's a whole topic we could go down to.
For sure.
Absolutely. And you learn them very quickly there. And you learn what your boundaries are, because I guarantee you they're going to get crossed, right?
Oh, yes.
Yeah. So
I could share stories about that.
Yeah. So I also think, and this is just my thought, and I would love your input, but if you have Selves who really haven't come forward yet, or selves that are more or less observers or watchers,
Mm-hmm.
and you go into, they're going to be on high alert, right? They're going to
Oh,
be watching
yes.
and observing.
Mm-hmm.
But I'm wondering, my hope is that when they're watching and observing other people that have the same
Mm-hmm.
other selves, that maybe that will prompt them to feel safe enough
Mm-hmm.
to let themselves be known.
Yeah.
Yeah.
You
That could be
know,
very
Yeah.
powerful.
The ability
that
to
could be.
observe and check things out and know, okay, no, I could talk here. Yeah.
Hmm. And
Mm-hmm.
maybe if they can't talk there, maybe they're able to feel comfortable and safe enough if the
Mm-hmm.
environment is safe. And sometimes that's an issue for people with DID. It's just not safe. But if they are feeling safe enough, maybe they'll let the others know that they're there.
Yeah.
Yeah.
Mm-hmm.
Being
That's
able to
important.
unmask.
Unmask.
Yes. Unmasking is a good thing.
Yes.
Yeah.
Mm-hmm.
Yeah.
Very cool.
I think that's
Yeah.
all I have. I think
Okay.
for that. Is there
Yeah.
something else that I'm not thinking of that might
No,
be?
I think that's
Those are
fantastic. I think that covers
great.
it really well. Hi, dear friends.
We hope you're enjoying the episode so far. We'd love to invite you to join Hearts Multiplied, our private online community for people living with a dissociative disorder, along with separate spaces for clinicians and supporters.
Inside Hearts Multiplied, we host live events just for you, including social hangouts, little story time, teen D&D campaigns, online gaming like Minecraft and Mario Kart, and vibrant message boards on topics like intimacy and OEA.
We also offer a supporters group and a clinical consultation group for therapists working with dissociative clients.
And We Garden System facilitate 8-week peer coaching groups where we work on internal communication and personalized healing goals.
To learn more and sign up, visit acoupleofmultiples.com. We'd love to have you.
So, when do you think inpatient hospitalization is not the
Hmm.
answer for someone with DID who appears to be in crisis?
That's a very good question, too. I think that when I think about that, I think about the individual client.
Mm-hmm.
Everyone's different. What is their personality? What are their
Mm-hmm.
triggers? All of those things that we have to be mindful of. I mean,
Mm-hmm.
everything we do, we have to be mindful of what is in the best interest in our client that won't do any harm. I'm
Mm-hmm.
first tasked with do no harm.
Right.
So I would be mindful of the personality, the personalities, and how they would fit. I think if someone is relatively stable and
Mm-hmm.
there are community resources that can help them, in other words, they can go to a PHP or an IOP, I would
Mm-hmm.
recommend that before
Mm-hmm.
inpatient.
Yeah.
Um, get into a group. If they have
Mm-hmm.
a great support system at home, if I feel like they're safe at home and they
Mm-hmm.
bring their
Mm-hmm.
partner or family in,
Mm-hmm.
and we have a family session and talk about it.
Mm-hmm.
We make sure the house is safe. We have a
Mm-hmm.
safety plan in place. Then I think we can try and see. And the next step would be either PHP or IOP that we spoke
Right.
about
Mm-hmm.
earlier before I put them
Mm-hmm.
in inpatient. If they're easily triggered and have maybe a greater startle response, the noises bother them being around
Mm-hmm.
people.
Mm-hmm.
I don't know. Sometimes I think hospitals can be more triggering for people with a lot of complex trauma, especially if they have a
Mm-hmm.
lot of littles. If they
Yeah.
have littles that are afraid,
Mm-hmm.
that's, I don't want to upset the littles. So,
Yeah.
I mean, there are a lot of different reasons why and why
Mm-hmm.
not. I think it's an individual basis and a clinical judgment call.
It really is. Yeah.
Yeah, if the only hospital nearby is not
Mm-hmm.
conducive to healing and isn't
Yeah.
trauma informed, then I think I would be doing my client a disservice.
Mm-hmm.
Another concern I have is if you're sending them to a hospital far away
Yeah.
and this person is struggling, how are you going to get them there? You can't put somebody who,
Mm-hmm.
well, we're talking about crisis. In crisis,
Yeah.
we're not putting someone on a plane, right?
Yeah.
But if they're not in crisis, this here is an answer to that question. Well, what if they're not really in crisis?
Mm-hmm.
They're not going to hurt themselves, but they really need help.
Yeah.
I worked in a hospital and we had someone just get on a plane to come see us and got lost and never got there. You
Oh
know,
gosh. Yeah.
they switched. The other part came out and off they went.
Yeah.
So
That
there's,
happens. You can't
yeah,
be by
that does.
yourself on the airplane.
Yeah. So there's a lot of things to consider. What are the dangers? What are the benefits? The
Mm-hmm.
cost reward? And is there a fear that this person is in a state where they could be easily manipulated or
Mm-hmm.
coerced, right?
Right. Yep.
Depending on
Those
the
are important
facility.
things. Mm-hmm.
Yes. Um, and if their needs aren't going to be met, if they're not trauma informed and they don't know anything about DID and they're
Right.
going to be dehumanized or
Mm.
ridiculed or,
Mm-hmm.
you
Could
know,
cause more trauma.
cause
Yeah, I've
more trauma.
experienced that myself. That was not fun.
That I can't imagine
Yeah.
how difficult that must be to go to a facility to get help and in the
Mm-hmm.
end you're re-traumatized
Mm-hmm.
or stigmatized.
Right.
Yeah.
Yeah. All right. So how do we keep people out, right?
Yeah. So,
Mm-hmm.
what are some safety plans that could be implemented to help prevent involuntary hospitalization?
Well, I think I've talked a little bit about that so
Yeah.
far.
Yep. Some
Yes.
good
And
ideas there.
I create, so first and foremost is, to have good communication and a good, if you're live in a family or you have a partner, make sure you have the support and that it's safe, that the
Mm-hmm.
partner is safe. That's first and foremost. Who are you living with? Are they safe?
Mm-hmm.
Okay. And then if we have that firmly established and you have a support person, have a good circle of influence that you can rely on for help. The home has to be safe. No sharps, no, weapons, knives, things like that, scissors. And just have an agreement. I would call the family member and say, we're not doing so well. The depression is increasing. The passive suicide thoughts are becoming more frequent. Let's avoid a problem. I'm worried about them. And then we would do that, of course. That would be the first step, right? And that's also a step that's important when you're coming home from a facility.
Right.
I don't know the research, so I can't quote it, but I forgot the number of instances of someone hurting themselves or attempting suicide post hospitalization,
Mm-hmm.
Yeah.
right? And there's also a lot of adjustment going back and a lot of pressure. Families expecting the patient to come back fixed.
Oh,
Oh yeah,
goodness.
like you should be
Goodness,
all done when you come back. You
be
should
all
be fully
done.
healed, and you
Mhm.
should be ready to go. And that just isn't the case.
Right. And why are you
No.
tired? You did nothing for weeks. You
Oh,
just,
my goodness.
You just went on a vacation. That's what I was
right.
told.
I
Oh,
heard that as a therapist. I heard that from family members and from patients. And it would be,
Mhm.
no, they're working all day, every day. This is hard work. They're
right.
exhausted.
Yeah.
Yeah.
And I think that's important to emphasize. Like when you're doing your trauma work, inpatient or out of patient, like it is hard work. It's a lot of work. Of course you're tired. Like,
Mhm.
and that's okay. It's to be expected.
Right. And if you're suffering with major depressive disorder or PTSD or anything else, you're already in a heightened state. Your anxiety is high, and now you're going to a new environment to try to get help. Yeah, it could be a vicious circle. So we need
Yeah.
to help them have an exit ramp. That's what I tell
Yeah.
my clients. We need to find the exit ramp, get off of the circle,
Yeah.
and try to help ourselves. So I have a safety plan, which I can send to you. I don't know if
Okay.
anyone
Yeah.
can see this, but I work from warning signs that I'm in crisis.
Mm-hmm.
I'll tell you what my warning signs are. I'm dissociating more. I'm having struggles with memory loss. I'm having suicidal thoughts. I'm emotionally overwhelmed. I'm not able to stay present, right? And then the next one is my internal system safety signals. What's going on internally? What does my internal system do when I'm struggling? So the person that's trying to help you can look at and see, oh, this is going on. This is their system at play here, right?
Yeah.
And if you know the names of the selves that are involved, then we can work on coping skills and strategies for those selves and how to talk to them, building a relationship with those selves, right?
Yeah, absolutely.
Super important.
Really, yeah, good support. They need the support too. Providing a list of coping strategies that help me stay grounded, you know, includes steps. How can I reach out for help? What are things I can do? And I would, again, involve the other selves too.
Exactly.
It's really important, right? Especially if you've got different ages and so forth.
We are capable of being our own support system internally. Like there are
Right.
other selves that help
True.
other selves. There's someone that takes care of the littles. There's somebody that manages things, and so utilizing those relationships is key, I think.
I agree. And I stress that with my clients. You have a whole internal support system. We can get everybody rowing in the same direction. And my gosh, how powerfully awesome is that when you have so much help, right? So we'll see. So, one of the things I do when we're talking about the warning signs I'm in crisis, I try to have the client think about the moment of crisis and walk backwards. I think that helps them think about the moment. And because they'll say, well, I don't really know what happens first or second, but I walk them through backwards. Okay, we're here. This is crisis, meltdown. We've got to do something. Fire. What was it? What happened right before? What happened right before that? What happened? And we may actually get more than a few steps, right?
Right.
So let's try to intervene here at the very first sign of trouble instead of letting it cascade.
Yeah.
Okay?
So smart.
It is.
Yeah.
It's really
So-
easy to fall into that place where you're like, it's not that bad yet. I'm okay, and like a
Right.
little bit of denial that you're slipping.
And that may be a warning sign.
Yeah.
I'm in denial. I also have them list what not to do when I'm in crisis, right? What if I don't like to be touched and somebody's first instinct is to grab and touch? That's not going to help me. What not to do is to say these words to me. There's people come up with all different things they don't want to hear, things that are triggering for them. So I think that's really important. So what not to do for me is just as important as what to do for me.
That's a really good point.
Yeah. And then I have the client write out a plan, my plan if I feel safe, in their own words, what they're going to do. And then I kind of have them write out some affirmations to themselves, my commitments to myself. What are some affirmations or internal agreements that you would like to have with your other selves to keep you all safe? And maybe assign jobs to different people in the system. Again, this teamwork, And then I have another step, a system map overview.
Ooh, system mapping.
Yeah,
we love that.
we know about that.
Yeah, that's really important. So, and I let the other selves do that. Draw out, tell me who you are. Tell me what your strengths are. Okay. And what your needs are. And this is all in one document. They can keep with them. And then I have a parts agreement page where they put their name and what they do, and they sign it and they date it. So everybody's invested.
I really love that you
Literally,
included all of the cells
yeah.
as part of the safety plan.
Literally on the same page. I love that.
Mm-hmm.
Awesome.
And then I have a page where I would review. This is therapist review and support, and I write on there. And then any notes that I have that maybe we've talked about other things to add,
Yeah.
and that's it.
That's
for that.
fabulous. Cool. So I'm actually going to skip this question because we've already answered it a couple times as we've talked about hospitalizations. And so for our listeners, it was what are the important considerations someone with DID should have when looking for an inpatient hospitalization? And we've definitely covered that, talking about trauma informed and all of those pieces already. So we're going to go ahead and move on to the next one.
Okay. So, what are some negative effects from going inpatient when you have DID, and how could hospitalization programs minimize those negative effects?
That's a good question too, right? The negative effects from going inpatient with DID. That's a tough one, but it is a very real question that I think that's a really good question to ask. Psychiatric hospitals are loud, usually. There's very little privacy. You have multiple individuals with multiple issues, different varying levels of severity. So how does the system going to respond to that? Are they capable of responding to that? What about privacy? There's not very much privacy. So I think they can be very triggering. There's a lot of energy, a lot of movement, and a lot of other disorders to contend with. And there may be a lot of there could be some clashing there.
Yeah.
Another issue that is also a negative, but some people believe it's a positive, but the trauma bonding, meeting with people, sharing your stories, everybody's talking about their trauma constantly. It's in vivo on steroids, right? And you can't get away from it. So that could be problematic. If you don't have a safe place to retreat to ground yourself. I mean, they're going to teach you grounding and everything, but if you can't get away.
Yeah. It's talking about trauma can be processing and healing, and also talking about trauma can be re-traumatizing.
Exactly. So there's a difference in processing trauma in a therapist-led processing group, or talking about cognitive distortions or using CBT or DBT and trauma model therapy, than sitting at the table during break or during arts and crafts as somebody's deciding to unload all the stuff that they've been holding inside, and you're sitting there and you have nowhere to go.
Right.
So I think that's problematic, the noise alone sometimes. And what if you dissociate when you're in the hospital, or one of your other selves comes out, right? Coming to in the hospital from a dissociative state, I can only imagine how frightening that might be. Where am I? What's going on? How, etc. And what if another self comes forward?
Right.
And they don't know that that's where everybody took us,
Right. And what if the other patients don't know about DID? And now you're the person that's, who is this? Is a novelty, right? This is right. They start asking a lot of questions. Again, working in a facility, we had patients who suddenly developed DID from talking with patients who did. And it was very upsetting to the patients who did have DID, because these others it was almost mimicking, I think, is what several felt like, it wasn't a good thing, right? If the staff is not well versed, doesn't know anything about DID, There are still a lot of clinicians that don't believe it's real. It may be in the DSM, but they don't think it's real.
Yeah, they think it's, therapist invented or something, like it doesn't work that way.
Right. And there are some that think it's attention seeking, and that's what they call out, or they treat them rudely. They don't understand what's going on. I mean, I have seen a lot of these things happen.
Yeah. So
Yeah.
making sure that the people actually believe in DID before you go.
Absolutely. And I think there could be nothing worse than, going to get help and nobody knows about how to help you.
Yeah.
And they make it worse, or you're treated with in a dehumanizing way or made fun of. I don't think that's healthy at all.
No,
So I think there are a lot of things to consider. Again, trauma informed, some sort of familiarity with DID and how to treat it.
I think training not just the therapist, but the behavioral, what do you call them? Sorry, the behavioral technicians, the
techs,
like, yes, the techs, like they need to know. There's a lot of training, I think, that could be very helpful. So, because leading into question 9, like, clients have a lot of unique needs when they have DID. So, like, what are those unique needs that clients with dissociative identity disorder have when they are in crisis and need inpatient hospitalization?
I think that's a good question too, and I think it kind of piggybacks off of this question. Again, recognition, people knowing what's going on and how to help them, how to approach someone when they're dissociated or when they're switching, how to identify. You don't walk up and say, "Oh, who are you?
Right.
Where'd you come from?" Hi, my name is, I noticed that you just joined us. How can I help you? A very calm, gentle, welcoming versus, I told you 3 times, get in group and you're not moving, right? No awareness, or what's wrong with you, or who's present? Which one are you?
Yeah.
I've seen that too. Which one are you?
Yeah.
And so I think people have to know how to approach people and be understanding and compassionate and know how to work with people.
Yeah. And I think it's important to add too that, the high prevalence rate of people with DID in inpatient facilities, like, this is not rare, like, if you're talking about the general population of the entire world, it's 1.5% according to the DSM, but if you look at more recent research, those numbers are higher. And if you narrow the population, if you narrow this population down, right, and you're talking about just trauma units in inpatient hospitals, in Bethany Brand's book, Finding Solid Ground, she comments that, when they went to the trauma units and gave the assessments, like 29% of the people inpatient qualified for a dissociative diagnosis, whether it was DID or not, but only like 5% had actually been given one. So there's like a huge discrepancy in being recognized even in inpatient hospitals.
Absolutely. And it's an underdiagnosed. I think the recent research is 12 to 15 different diagnoses, or 10 to 12 years before someone gets the diagnosis. Yeah. And so I can't imagine being misdiagnosed that long.
Yeah.
So, I think you made a good point too. And just knowing about how to approach people, how to approach someone, even if they've switched, because sometimes switching is, from my experience, and is subtle.
Oh, very.
It can be very subtle. It's not this dramatic, sometimes, but very rare, this dramatic.
Most of it's subtle, Every now and then there's some that are more obvious than others, or systems that are a little more overt than covert, but the majority are covert. And like, that's the reminder, like, DID is meant to be covert to the point that even you don't know you have it.
Right.
And that's important to remember.
Yes. So the mask is on. We're
Mm-hmm.
protected.
Yes. Yep.
Yes.
That's kind of the point of it.
Mm-hmm.
Yeah.
Yeah.
Mm-hmm.
So
Yeah.
this next question is similar to some we've had, but maybe you want to add something to it. We'll see. What does hospital staff, admin, therapists, and behavioral techs need to know or be aware of when it comes to dissociative identity disorder?
I think we've covered this quite a bit.
Yes.
But I think learning to be attentive to their body language and their tone of voice, because trauma survivors, whether you have DID, PTSD, complex PTSD, there's this hypervigilance, right? They're very aware. They're looking for danger. So they're going to read your face, right? So learning how to have a poker face, be gentle and calm and open and soft, and be careful when you're walking up. Don't just walk up and touch somebody or sit right next to them. It's always a good idea to say, hey, do you mind if I sit down and talk with you? Ask permission.
Yep. Permission is important.
Respect boundaries. Right. And, just in general, try not to re traumatize the patient. And do not talk about the patients at the nurse's desk where your patients or another patient can hear you. Be very careful about what you say.
Because they're listening.
They are listening. And when you think they're in bed asleep, still be quiet, be careful, right?
Because they're listening.
They're
not
listening.
sleeping.
And, it goes back to trying to be sensitive and know the client, read their chart, know what's going on with them, have some information about their system. If it's been provided at intake or their history, read about it. And if you know they have littles, be aware of that.
Yeah. So I think we can combine 11 and 12 together. So why don't we put that together?
I love
All
it.
right.
So you go ahead. Just read them both.
Oh, okay. What are signs that someone is experiencing dissociation when they are inpatient, and how do you differentiate when someone is having a dissociative experience versus a psychotic episode?
Yeah, two very good questions. And the second one isn't always that easy to differentiate, right? Otherwise, DID wouldn't be so misdiagnosed, right?
Exactly.
So the signs that someone's having an dissociative experience when they're inpatient, well, we know dissociation can show up and look different on different people, right? Sometimes it's that they're just still that far off look, and that's an actual dissociative state. They're there, but they're not there.
Yeah.
Right.
And that's common. We see that a lot in hospitals. We know that that's a protective factor. There's something triggered them. They're fearful. They've gone in. So that is always a sign. This is kind of a hard question for me. Let me see. I just, to me, the way I just do it every day. So I'm trying to put it into words, but I'm very attuned to my client's body language, their tone of voice, how they're sitting in the chair, how they're reacting, how they're responding. So that's always a change because sometimes it's very subtle. So we're talking difference between differentiating dissociation from another self coming forward. So dissociation, they're gone. They're not there. They have checked out. And I had a client do this today in my office for about 2 minutes. And it's happened before. And I was very careful. She had a memory of another trauma and started talking about it. And I was very aware about her body language and how she was handling it. She seemed fine 1 minute. And then all of a sudden, I looked up and she was literally like staring straight ahead. And I knew she wasn't there. And I just gently, quietly, softly called her name. and said,
Mhm.
you're safe, you're safe,
Mhm.
you know.
Mhm.
Talked to her a bit, and then she came back into the room, and she was literally having flashbacks in that moment.
Mhm.
Everything's flashing through her brain, but
Right.
very soft, talking very softly. You're safe, you're safe. It's
Right.
2025, you're safe, you
Yeah, that
know.
softness I think is really key because, like, when you're trying to
Yes.
bring somebody back, that's in a
Mhm,
flashback that is dissociated, you can't
mhm,
shock somebody back. It has to be a
mhm,
very gentle process.
mhm. And
Yeah.
I don't touch her either.
Right.
I
Mhm.
did ask when she started to come back. I
Mhm.
keep frozen limes and lemons in my office. I have a little freezer, and I said, would you like for me to get you something really cold to hold? And she loves them, and she grabs it, and it just really jolts her that
Yeah.
last bit back, and she
Mhm.
rubs it on her forehead and her
Mhm.
neck. And
Mhm.
then I have other things that she can touch and manipulate, and I
Mhm.
just let her come back at her pace,
Right.
just how
Mhm.
can
Perfect.
I, sometimes I'll say, what do you need from me right now? Or how
Yeah.
can I help you in this moment?
Mhm.
And
Yeah.
sometimes it's just sitting there in silence, you
So
know?
I
Yeah.
really want to reiterate for the clinicians listening, like the importance of asking permission before handing them something cold that could feel
Hmm.
somewhat shocking. Like
Oh,
they need to
absolutely.
be prepared for it.
Hmm.
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 Yeah.
And I even asked her if I could approach first. Would you
Hmm.
like, can I come closer? And I
Yeah.
did that. But
Hmm.
I didn't sit next to her, I sat across.
Hmm.
Um, so let me think. So that's when they're dissociated. What was the other question? Did I miss it? Is there something that
Well,
I'm
just
forgetting?
differentiating between the psychotic episodes and
Mm,
dissociation, like when somebody's having a delusion versus or hallucinating. Yeah, hallucination is the correct word, versus having a hallucination versus having a flashback.
yeah, there's a difference, right? A
Hmm.
hallucination is they think they're seeing something right then and there in the present, and the flashback is literally that you're flashing back.
Hmm.
Um, and mental health professionals, we have to observe
Hmm.
someone for a bit. It's not a snap decision all the time. Sometimes it's hard to differentiate
Hmm.
what's going on, right? Because they can look the same. Um,
Hmm.
so I will also I might ask them some other questions like, tell me what's going on right now in your body. What are you feeling? I
Hmm.
don't feel my body.
Hmm.
I don't think I'm in my body. Well, there's a dissociative or
Yep.
experience right there. If
Hmm.
someone is um, talking about, if they're psychotic, they're going to have a break from reality. They're not going to know the difference between what's real and unreal. Dissociative identity disorder, you still see through the same eyes, you breathe the
Hmm.
same air, you know. You may
Yeah.
interpret it or experience it differently, right? But
Hmm.
they can still communicate. That's not a psychotic break, right? You
Yeah.
know certain
Hmm.
things about yourself. Psychotic episodes they do hear voices,
Hmm.
you know. But I often ask, where are the voices coming from? Where do you hear the voices?
Great question to
That's the
ask.
important one.
Outside. Are they in your head? No, they're somewhere over here. They're all around me, or it's
Hmm.
like a speaker in my brain, just right.
Hmm.
So
Yeah.
those are some indicators. But again, still, I would not make a diagnosis unless I did some definitive
Hmm.
assessments, right?
Yeah.
And then I would also have a psychiatrist do a psychiatric evaluation.
Hmm.
So psychotic episodes tend to last longer than a dissociative state.
Hmm.
Dissociative states are generally not too long, and you can bring
Yeah.
someone out of it quickly. But if
Hmm.
someone is psychotic,
They're not
it's an
coming back.
altered state of
Yeah.
mind. They're not coming back.
Hmm.
They have difficulty. There's a lot of other signals with that, right? They have trouble
Hmm.
with social relationships and
Hmm.
difficulty functioning and so forth.
Hmm.
If they have schizophrenia, things like
Hmm.
that, you'll know
Yeah.
that. People with bipolar, it's
Hmm.
possible to have a psychotic break too.
Hmm.
But So
I think it's
people,
important that we mention those diagnoses, right? Because those are some of the common
mhm,
diagnoses people get when they really should have gotten DID. Is they often get misdiagnosed with bipolar because the switching can look like mood swings. They get
right,
diagnosed with schizophrenia because
mhm,
they say they hear voices, but they're hearing internal voices, not external voices. And
mhm,
those
mhm,
are some things that, I mean, it takes more than just
mhm.
those two symptoms to really figure out what's
Right,
going on.
right.
So
And
don't
often,
be so quick to slap a label on.
well, and I think anyone who just does that by observing is
Hmm.
could be missing a lot of things. There's
Yeah.
certain assessments that are given for people who are we think they have schizophrenia. There's a
Hmm.
battery of tests. Schizophrenia has a lot of added symptoms that come
Hmm.
about, and they have a lot of negative symptoms, very flat affect. So there
Hmm.
are a lot of different things to think about. And somebody who has another self that is fronted now could present the same way. So
Yeah.
there's a lot of different ways.
Hmm.
Yeah, reality testing is something. Some will do Rorschach testing and things like
Hmm.
that. So there's a lot. I'm not credentialed to do those testing. So I would
Hmm.
send somebody for
Yeah.
further evaluation and
Hmm.
see if they come up
Hmm.
with a similar diagnosis. You don't
Yeah.
want to mislabel somebody.
It's
So,
important
we
because
use
it matters.
diagnostic interview school tools.
Yeah.
I use the mid analysis a lot.
Hmm.
But, those tests are only as good as what's going on with the client or the patient in that moment,
And this
right?
is true because most people with DID do have a self that, quote, knows how to answer these questions
Mm-hmm.
to go to
Mm-hmm.
fly under the radar. And a lot
Mm-hmm.
of times it's not really what the results of that test say, but the clinical judgment while you're giving the assessment and noticing
Exactly.
that. Hmm.
Exactly. So that's something to be very aware of because some
Hmm.
clinicians go, well, I'll just give the mid-analysis before I do my EMDR or whatever modality I'm going to use.
Hmm.
Oh, it says I have DID. I've had
Hmm.
it come back 2 different times with a client that has said they had DID and they didn't.
Hmm.
You know, they didn't.
Hmm.
Um, Bipolar, but no
Hmm.
DID. And
Yeah.
I know there's no DID. I've seen this
Yeah.
person for 6 years. I think,
Hmm.
but anyway, that's it.
Yeah.
That's what I would do. Assessment, assessment, assessment.
Yeah. And like our previous episode that we have is, like you're always assessing, you're
Mm-hmm,
constantly looking
mm-hmm,
and
mm-hmm,
reevaluating.
mm-hmm. And
Mhm.
with a psychotic break, a lot of times the cognitive functioning is off too.
Yeah.
There's a lot of other things, that
Hmm.
go along with that. Their judgment is very poor. So,
Hmm.
but again, you can't just pick out, I see these symptoms and
Yeah.
it looks like, so it is.
Right. Yeah. All right. So, what are some things that inpatient treatment programs get right for clients with DID?
Oh, good question. You're making me
I
think on this one. Um,
think all of our listeners are laughing right now
yeah,
because
yeah.
they know how hard it is to get a place where they do things right.
If a facility is able to provide safety and stabilization, number one,
Hmm.
that's number one,
Yeah.
right? If the patient feels welcome, validated, seen, and heard, and safe, ah,
Hmm.
you've
Safe enough, at least.
safe enough. I was going to say we hit the trifecta, but that was 5 things. So I don't know what that would be. But again, specifically for DID, when you're in a facility that understands DID and knows how to work with the patient, that
Hmm.
patient feels validated and recognized,
Hmm.
and it is conducive for them to do the work. A skilled
Hmm.
clinician will not pathologize or dismiss a patient, right?
Hmm.
They're going to not label the behaviors or the actions as bizarre, childlike, delusions,
Right.
attention seeking, all of those things. So all the things we don't want, okay, they don't do. They need to be able to understand and notice when another self comes forward. It's very subtle, but what do I do? How do I manage that? And most of the time, that's talking to the patient, getting to know the patient, getting the history, talking. My patient, I would say, what do you need from me? When so and so comes forward, what is the best way for me to work with that part of you? What works, what doesn't, Um, fostering internal cooperation. That's so important.
Yep.
If they're fragmented and fighting, then you've got a World War III going on, right? And how are you supposed to be able to do any work? So, helping you develop internal communication with your other selves, right? That's first and foremost, creating safety for each one of them, creating safe spaces for each one of them, helping you help them to go into a safe space when we're about to have some conversations or some processing that is not appropriate for them. So being cognizant of what is helpful and what is not, and just realizing you are talking to a system, right?
Right. And you don't necessarily need to keep asking for the legal name on the driver's license, because that may not be who you need to talk to.
Exactly, exactly. And learning how to gently engage the other selves to come out, to talk to you, invite them to come out, validating their feelings and their presence. Oftentimes they're dismissed, right? But no, come on out. You're welcome here. How can I help you? A very soft, gentle, kind, inviting voice, encouraging that, helping to build that trust, and helping the system to build their own internal trust with each other. Isn't that important, right? So another emphasis on grounding skills and coping skills. I mean, that's a basic thing, teaching people how to ground, practicing it. And you mentioned Bethany Brand's book. I
Finding
love that
solid
book.
ground.
Solid Ground. Thank you. I couldn't remember. And that's very good. There's some very good interventions in there that are more advanced, a little bit different, new ones to help.
I really appreciate how she spends the first couple of chapters really emphasizing the importance of being able to recognize and being able to emphasize like the cost, that goes into, the treatment and everything. Like there's just a lot of really good numbers. The research there is solid to really show how underdiagnosed this is and the
Yes.
impact it has, and why it's so important for hospitals, inpatient programs to really get to know and understand this diagnosis more.
And, these individuals that struggle with DRID are human beings like everyone else. They have
That's
a
right.
wealth of experience in life. They have a lot of skills. They look like everyone else, and many are very successful people,
They are,
right?
yeah.
So let's not dismiss or minimize them. Also a holistic approach, again, working on mind, body, spirit, nutrition, sleep hygiene. What can we help you with that you can do? What can you do for yourself to help the body be able to heal? And sometimes the best thing is getting a good night's sleep, right?
Yeah.
Learning quiet time, how to regulate your emotions. I love this clinic that we talked about earlier. I love the idea of using polyvagal to help, work on the nervous system. I think that's really cool. I think another important thing is a structured daily routine.
Oh, yes.
Structure is so important, but with enough breaks, right? Breaks in between and some downtime. I think regular exercising, having a program that incorporates recreation, most of them do, and really encourages the patients to move their body. That's another important thing too. And ground rules, ground rules when in groups, setting firm boundaries, what's appropriate, what's not letting one patient run the group or take over. There's always something like that. And ground rules about dissociation when you're in group, because sometimes there is the dissociative, people will dissociate because they don't want to participate. So having some rules about that, and also having grounding techniques, having things ready to help the patient. So when they do dissociate, that they can get help. And I think make sure the facility has access to a multidisciplinary team. I think that's important. You have to have everything. And I think that they use a stage of change theory, an 8-step, or I think it's a ladder of support, 8-staged model of treatment, stabilization, safety, processing the traumatic memories in a way that doesn't re-traumatize, and working on rehabilitation and getting the group internal communication going and getting everybody going in the same direction, and helping the patients build the resources that they need, new coping skills and other resources, providing other referrals to other facilities, perhaps providing EMDR.
EMDR is so helpful. So
it really is.
Let's just acknowledge that, like, you can do EMDR with people that have DID. And we'll talk more about that in another episode, but I just want to emphasize that.
Absolutely, you can. And then I think also a smooth discharge plan is really important. Backing up, involving the system in treatment planning too.
Yeah.
So, here's a real important part. I just thought of this. Creating the space for littles.
Yeah.
There has to be acceptance that some people have littles, and there has to be an opportunity and a safe space for the littles. You can't forget them.
Right. And sometimes in a lot of systems, a little might be the gatekeeper and might be the way in to talk to everybody. And that's important to recognize, and, and in teaching how to share time, and giving time for the littles to have their space to talk about what they need to.
Absolutely.
And let's remember, like, the littles are the ones holding the trauma. They often are trauma holders, and they are the ones that need to process and talk about what has happened to them.
Right. And to that point, if they're a little, then when you're processing with the little, you have to process with them as a little child, not using adult interventions on a small child. So arts and crafts, play therapy, things like that would be good. I do art therapy, pour painting with my clients. I have a few that have dissociative identity disorder, and they have the little parts. I have little canvases for them and bigger canvases, and the little always gets to come first. Going to make a little weight. I mean, come on.
They're not good at that.
No. So, and having some kind of understanding, like a basic understanding.
Yeah. And then another important piece with littles too is that, yes, they're going to present, at that developmental age sometimes. And sometimes you have to be careful with exactly how you talk to them. But we also need to remember that they are not the same as, say, the 4-year-old at the preschool down the street.
Right.
Like,
they've been in the body for
like I think of our 4-year-old Jenny, like, okay, she's been 4 for like 30 plus years, almost 40 years, so that is a very different presenting self than your typical preschooler at the local school.
Right, exactly. So
yeah, they don't need baby talk.
What?
I said they don't need baby talk.
Right, they don't. So I can't think of anything else.
Yeah.
I don't
I
know.
think
What
I
do you
think we
think? Have I
really kind
missed
of
something?
covered. I really think the way you answer this covers 13 and 14, because 13 was
Yeah.
like what do they get right and 14 is what are they lacking, but we really just talked about this is what is needed. And I think that's
Exactly.
the most important
It
piece
is.
here, So
I
and
think.
like really we've covered this other one too, but like let's just go I really want to kind of tell a little story here about this one. So I'm going to read the question first.
Okay.
How can hospital staff and behavioral health technicians be more helpful for those living with DID? And I'm thinking about my own experience with this one particular behavioral tech who I will leave nameless at this time, but she was amazing. And she knew exactly what to do when we were in crisis and dissociated, in a serious dissociated state, while we were inpatient. And I mean, she knew to go to the freezer, to grab the frozen Go-Gurt, to play catch with us, to make us toss it back and forth. She knew how to talk to us in that soft voice. She knew to do things like ask us simple math questions. Like she knew all the grounding techniques, and she was able to bring us back so fast. It was like she could have been a therapist herself. Like she was really good at it.
Wow, that's
Um,
wonderful.
and that's, so like part of my answer to this question I'm asking you is like, even the behavioral health technicians, they need
Hmm.
appropriate training for
Hmm.
grounding and for people who are dissociative, so
Hmm.
that they know what to do when it
Hmm.
happens and they don't just like walk away or write you off.
Exactly.
Hmm.
Yeah. It's a system wide problem. And I don't think it's just the unit that
Yeah.
you're on.
Hmm.
Okay. The management of the unit.
Oh,
I mean, the
yes.
management of the hospital, the other people that are coming on the unit need to know and be educated as to what's really going on, because patients are moved from a unit in the psychiatric hospital to like the recreation center or to the cafeteria or wherever,
Hmm.
and they all need to be aware,
Yes.
right,
Yes. Hmm.
and sensitive.
Yeah, I'm thinking about too, like when I was inpatient, going to the cafeteria, and of course, usually when we got there, it was a nonverbal
Mm.
alter that was out, right? A nonverbal self that couldn't talk, and that man did not want to give us our dinner because we quote wouldn't ask for it, and the behavioral tech was like, "I'm not talking for you."
Mm.
And it's not like that wasn't about enabling, behavior. It was we literally had someone that did not have the ability to speak at that time.
Right.
When
And
you're in crisis and when you're not, and very much in control of your system, like it's not like you can control who's out.
mhm. Yeah, there's so many other ways they could have handled that, because that was
Mm-hmm.
also, I'm sure, very embarrassing for you,
Mm-hmm.
very
Yeah, and
shaming,
frustrating. Like there was just such
frustrating.
frustration.
Mm.
Yeah,
I'm sorry that happened.
yeah. It worked out.
Wow. I don't have, did you ask me another question? I don't know.
Or just,
Okay.
is there anything else that you can think of, for what would be helpful, like for hospital staff to know?
No, I think we've covered it.
I think we
Um,
Yeah.
have,
I
This
yeah.
has
think
been
we've covered
amazing.
it.
And a lot of fantastic,
Yeah.
amazing
This is
information
good
here.
information for everyone out there.
Well,
Absolutely.
thank you.
So, yeah.
Yeah. Is there one last thought you'd like to leave with our listeners today?
Mm, don't be afraid to ask for help, and do your research, and don't trust yourself with just anybody. If
That's
the
right.
first therapist doesn't work, it's okay to find somebody else. It's important.
That
And
is
if that
important.
person's a good therapist and they recognize that you're not a good fit, they're going to offer to help you find somebody to help you, because that's
Hmm.
what's most important.
It is.
Right.
Absolutely.
Beautiful.
Oh, thank you so much for sharing your thoughts with us today and your experiences. We really appreciate having you.
Thank you so much. It was my pleasure to be here. Thank you for inviting me.
Oh, you're
Yeah.
welcome. All right.
And thank you, dear listeners, for hanging out with
A couple of multiples. This episode is brought to you by Donna Earle, a licensed professional counselor and certified clinical trauma professional.
She's the founder of To Life Counseling in Southlake, Texas, where she helps individuals ages 17 and up heal trauma, navigate identity, and reclaim inner peace. Her trauma-informed approach includes EMDR, parts work, strengths-based therapy, TBRI, and CBT.
She's passionate about honoring the resilience of the human spirit, one story at a time. Today's episode is brought to you by
Selves Therapeutics, PLLC, a mental health practice located in North Carolina, specializing in the treatment of dissociative disorders and trauma. Healing Selves is committed to serving the plural population through the utilization of EMDR, clinical hypnosis, expressive arts therapy, and other evidence-based practices.
Healing Selves was established in 2019 and currently serves North Carolina and Florida. We are committed to extending accessibility and currently accept most commercial insurances, Medicaid, and Medicare. Thank you, dear friends, for spending time with us today.
We're so grateful for each of you and all the important work you're doing. Whether it's supporting others or navigating your own healing journey, we hope this episode brought insight, encouragement, and something new to consider.
If it did, we'd love for you to share it with a friend, your therapist, psychiatrist, or colleagues. It's one more step toward changing how the world understands DID.
And just a quick reminder, this podcast is for educational purposes only and is not a substitute for therapy. Listening does not create a therapeutic relationship with the hosts or any guest speakers.
Until next time, take gentle care and thank you for hanging out with
A couple of multiples.